I'm Leslie London, so I'll just introduce myself as from the Division of Public Health Medicine at the University of Cape Town. And thanks everybody for attending this webinar. It's one of a series that's co-hosted with Healthcare Workers for Palestine and Health Justice Initiative to try and get more information about what is going on and how we should understand what is going on. So I'm really pleased that we managed to get Zeina Jamaluddine, who's a research associate at the London School of Tropical Medicine and Hygiene. Many of you will know that the recent report on prediction has come out, and it's providing really important information now. And what's the statistics? 1 in 25 people in Gaza are either dead or injured, and that's pretty shocking. And another 25, as of yesterday, 25 people have died of malnutrition and dehydration, including 21 children. So we hope that the predictions don't come true, but we can see it happening before our eyes. And as we were chatting just before the meeting started, many of us in public health know these challenges. So we're really looking forward to your presentation, Zeina, and then we'll take some questions. So I'll hand over to you. Thanks very much.
Thank you, everyone. Thank you for the invite. So I'll be sharing a screen, if that's okay. So I'm mainly focused on the work that we've recently done to basically project what is the impact of the public health crisis or the war in Gaza. These are projections, not predictions. So it's important to note that we cannot predict what's going to happen. However, we're trying to see in different scenarios of what would happen in the future, what would be around the excess mortality in different scenarios. And so I just want to say that this is a team of work that was been done between London School of Hygiene, Tropical Medicine and Johns Hopkins University, with different people contributing to different models and specific areas to do the modeling. I want to start at the beginning by saying that we know that currently there's been reports of more than 30,000 people who were killed by Israel. This number also increased further in the past week to 31,000. The majority of them are women and children. However, it's very easy when we talk about numbers to forget that there are people behind these numbers. And so I just want to take a moment before we start talking about all the numbers and all the excess mortality, is to say that according to one of the poets who was killed in Gaza, like, we are at the upper sky now, building a new city, doctors without patients, without blood, teachers without crowding, nor shouting at their students, new families without pain and sorrow, reporters filming heaven. And I want to take a moment to acknowledge some of the people who were killed. Moving forward is to talk about what the project was trying to do. So within this project, as you just mentioned, is really to inform decision makers about the estimated health consequence of the war in terms of humanitarian response. So how much we need and where we need and what needs to, where are the areas that will be problematic in the next 6 months, but also to talk with diplomatic efforts. The war, as we know, has multiple effects, not only on mortality, but also on morbidity, access to care and healthcare, and also has a ripple effect. However, we use this as a last downstream outcome to project the excess mortality. Basically, this means the mortality over and above what is expected in this period. So we know that in a certain period, we'd have mortality more likely for children, for infants actually, and then for elderly. And this is something, a pattern that we know well in public health. However, this is really to project what would be the excess mortality over and above what would be usually occurring during this period. The way of working was trying to be reproducible, and so everything we have is available on GitHub and on a publicly available platform. People can reproduce the analysis, and we got ethical approvals from universities. We also have a website. You might have seen it. We have attempted to translate to Arabic and Hebrew the summary of the projections. We have started talking to a few stakeholders whether it's UN or also diplomatic efforts to try to showcase what's going to happen in the next 6 months in terms of projecting. And at the same time, if you want to have a scanning the QR code, you could have access to the website. Now, in terms of methods, I will go a bit quickly so that I don't go in a lot of details, but everything is available. Also, if anyone wants to particularly look at a particular methods for projections, it's also available to have a look at them, and with an annex that's like 70 pages. And so in terms of the projections, we clearly defined 3 big scenarios. The first one is a permanent ceasefire. So basically with the assistance coming in and the stopping of the military activities and the bombardments. Then the second scenario, which was more of a status quo, which we took a period in the middle of the war, between the 15th of October and the 15th of January, and used that as saying that things would continue in the same way. And then an escalation scenario with an attack in Rafah, there's a lot of talks and has started actually. So there's all of that, these 3 different scenarios that we've basically used to come up with the projections. We used to define the scenarios, we used the intensity, the population movement, the occurrence of a ceasefire or not, or whether those humanitarian pause would happen in the middle, and how much humanitarian assistance would come in. And we aim to maybe change the scenarios depending on how things improve, but also, as you know, in all modeling or in all data, public health data, it's all about the data that we have. So based on the data we have, we did these models. If things become more available, we could also improve the models. We project in the period of 6 months, so from February 7 to the 7th of August for 6 months. Then just want to say that we know that in wars, the aerian and ground invasion and basically like the bombardment leads to direct excess death and direct effect of the war. We also know that there is the indirect effect of the war from poor shelter, from disruption of healthcare services, so people not able to go to healthcare services, from the very insufficient water and sanitation, insufficient food, and these also could lead to excess death. It's also important what we also try to distinguish is all of that with and without the occurrence of an epidemic. So, so we know that these circumstances would also increase the chances of an epidemic occurring. And so if an epidemic occurring, they would also contribute to excess death. And so in terms of like the different disease areas, so we have modeled the increased mortality from traumatic injuries. So people who die immediately from bombing, from death due to wounds, so not untreated, as we've heard a lot of the reports of that. But also death from infectious disease endemics. So whether it's like stuff that, for example, influenza or RSVs, and we've modeled these, but also we've modeled the probability, but also what would happen in terms of excess death if an epidemic occurs. So if a measles outbreak happens, or a polio outbreak happens, or a cholera outbreak happens. And then we also looked at mortality due to maternal and newborn death. So here we don't refer to maternals and newborn who die from injuries. How it's really linked to the fact that they're not able to access the healthcare they need. So, so in terms of NICUs for babies and preterm babies, what would be the excess death? And if they had access to these, how many lives would be saved? The same thing for NCDs. What we try to look at is, in fact, the excess deaths from not being able to go to hospitals for ischemic heart disease, from for kidney dialysis, so all of that. The more you miss kidney dialysis, how much excess death increases. We also modeled malnutrition as an underlying cause to all of this, and because it contributes to different disease areas, and we have also omitted some disease areas that we needed more further expert elicitation and expert review. For example, type 2 diabetes, although we know that COPD, for example, is leading to excess death currently because there's no access to oxygen. However, it was harder to model it due to the fact that we did not have enough research to be able to build these models. What I want to say, this is a first attempt to build something in the middle of a conflict, and so the methods and all of that has been shared widely to try to be transparent, and so one thing to notice about Gaza is that Gaza before the war had a lot of data. It's a very data-rich country, unlike some of the places where I've worked before, where there's Syria. The data that was available in Gaza about the condition and the healthcare system was very rich, and we used this data from the Ministry of Health, UNRWA, which is the UN agency that works with Palestinian refugees, and WHO. We also use data that's coming out from the conflicts, and here we know the data becomes more patchy and not always available. And then also we relied on expert elicitations. So specifically for some of the models where we needed to quantify the case fatality. And so I can further show them. And in terms of then the methods, I will definitely not go in details, but just to say that some of the methods have been used before, like the LifeSafe tool. And this one has like around 2,000 publications and has been heavily used. However, mainly to model what would be the life saved. So what we're trying to model here is how many lives would die due to lack of access to healthcare. And this is used for the maternal newborn. And other models, we have built them in-house using, for example, prevalence, but also understanding the case fatality. So just to set up the scene, as most of us here work in public health or have a medical background, what we did is really look at the epidemiological risk factors. So in the case of, for example, in the status quo, what is the mean liter of water per person per day currently being provided in shelters? And we know that it's around 8, so 6 to 10 liter per person per day. In case of an escalation, you could expect, for example, we would assume that it would be around 3 to 6, and in case of a ceasefire, we would assume something around 20 to 40. It's important to say that the minimum survival is 15 liters per person per day, and so we use this type of information to understand how many people per toilets are happening. So around 450 in the status quo are using one toilet. And all of these factors, we know how they would lead to excess probably mortality from infectious disease. The same thing for shelters and the same thing for nutrition, and specifically also the healthcare system disruption. So we try to see how much access to treatment and how much access to hospitals happen. And so in the case of a ceasefire and in case of we'd expect things to not go back 100%, but in the next 6 months, but however, they would have more access to hospitals, whereas in a status quo and an escalation, it becomes even further more, and how they contribute to different disease area, whether it's NCDs, maternal newborn, infectious disease. And so in terms of some of the results, and so what we see in the light green here is actually the excess mortality. So over and above the mortality that would happen in a period, in terms of a ceasefire, would be around 11,000 in the next 6 months in case of an epidemic occurring. In the case of an escalation, it could reach around 85,000 excess mortality. And that also we try to break it down by age. So in the light green, you'll see the excess mortality and based on the ages. So this is the annualized death rates, and in numbers are actually the relative risk. So how much more likely as an age group you're to die, basically, based on the 3 scenarios. Something that more humanitarian agencies use is actually look at crude death rate per 10,000. But what this really is saying that in case of a ceasefire, in case of a status quo, in case of an escalation, the increase is by 7 times more likely to die in case of a ceasefire, 34 times more likely to die, and then 43 times more likely in case of an escalation. And the light gray is basically what would be expected so this is on the bottom is what would be expected in that period. So I will not go in a lot of details, but just to say that in every specific theme, we built the models to reflect basically the excess mortality, and we took into account and removing the baseline mortality. And so for the traumatic injury one, that's a bit, we've heard a lot these numbers of 31,000 and all of that. We know that this is an underreporting according to the Ministry of Health, and in the Palestinian Red Crescent, there is a lot of people under the rubble and not unaccounted for. Also, people who are basically died but did not go to hospitals. Those are not counted by the Ministry of Health. And so we attempted to also include in the projections the unreported death, as these are less likely to be able to go to hospitals and very high probability of dying. We also, for that, we used the Ministry of Health data, but we also used UNRWA's death rate per 1,000 population, and we used that gap to really try to understand what would be the underreporting based on the gap, because you wouldn't expect that UNRWA is being targeted in a different way than the general population. The other element we did is actually look at death from wounds that are untreated. So, and at the same time, in the case of a ceasefire, we would also see death from ordnance and unexploded ordnance and death from wounds. We also used expert attestation to try to understand like what's the case fatality rate from the death from different location. And so in terms of traumatic injury, this is the biggest contribution of mortality in the escalation scenario, but also the other indirect effects would also have equally as much mortality. But here we see that in lighter color are the immediate death, and in the darker color you'd see the death from wounds that are not treated, and mainly people who were killed, who would be killed in the next 6 months. We also, for one of the scenarios, looked at the population distribution. In this case, in the light pyramid, you'll see the population distribution of the before the war of Gaza, of males and females, and in the dark you'll see the projected mortality from injuries, specifically based on also the ages. This is the y-axis. And you'd see that the majority of the people who are killed are children and women, but also there's a bulge that's happening among men that are 20 to 30 years old. This could also be due to the fact that some of them are fighters, but also some of them are actually the ones going to get food, as we've seen in the last flower distribution, where basically a lot of the people who were killed were men from that age group. The same thing for first responders and so on. So in terms of food, you've mentioned at the beginning, and this is one of the biggest concerns I currently have as a nutritionist who's worked on that in the region, is the fact that we know specifically that before the war, 77% of food in Gaza basically was coming from food assistance. So people were heavily reliant on food and cash assistance for food. And since the beginning of the war, what we did for the modeling is we looked at how much the decrease in agricultural land happens over time, but also how much the market basically doesn't have any more food. And then we looked at how many food trucks came in, and we quantified the amount of calories within these food trucks. We know that during that period, we would expect around 17,000 to 20,000 food trucks entering. However, during that period, only 5,000 food truck came in. And so the first graph is the food trucks that came in over time. And then the second graph is to look at how much calories is coming in per capita. And we use that to actually look at estimation and modeling of weight loss. So how much weight loss will happen among adults. And then we translated that to children, because acute malnutrition is the way is mainly measured for children and 6 to 59 month old, so 6 months to 5 years old. And just to just say that with the calorie decrease, we'd see a decrease in weight loss, and we started to see that, especially with adults and with children. And then with the projections we have in light gray, the ceasefire scenario, which means that maybe food would come back to the normal it was coming, and then in case of an escalation, the food would still be restricted. I think it's very important to note that when we did these models, it was the beginning of February, so then we could start seeing for the specifically for the nutrition, we could start seeing that the food truck was coming back in. However, in the end of February, the food trucks significantly were decreased by half. And so we're currently in an escalation scenario. And just to explain what we're seeing is, in fact, before the war, acute malnutrition prevalence was around 3% to date. So that means until February, it's around 14%. And we started to see these numbers coming up. And then in terms of an escalation, the number prevalence becomes 24%, which is classified as catastrophic and resembles a lot of places where we see famine. And so, as you mentioned in the morning, the past week or 10 days, there's been 27 deaths from starvation and dehydration. And this is basically something that the UN and different people and actors have been warning against since December. I'll move a bit more quickly in terms of infectious diseases. What we did is sort of trying to understand what happens in terms of vaccination and how vaccination decreases in terms of how many people are able to get it, but also to track the immunity. We also used expert elicitation to quantify the probability of an epidemic, so and the reproductive number and the case fatality ratio. And it's just to say that before the war, infectious disease was not one of the largest contribution to death in Gaza, and the number was very small, as you can see in the green here. However, during COVID-19, that increased in terms of mortality. But from other infectious disease, this wasn't a major concern. With the projections, we'd expect basically an excess mortality coming from COVID-19, but also from influenza and pneumococcal disease in the next 6 months. And we did take into account the seasonality of these diseases. In terms of an epidemic, and this one is a bit trickier because the pathogen of cholera or others have not been detected in Gaza since 1980s. However, the probability keeps increasing with the fact that the sanitation and the water situation. And so we looked at the probability of an epidemic occurring. And in fact, if an epidemic occurs, there would be a huge toll of excess mortality from around 5,000 in the case of a ceasefire to 8,000 in the case of a status quo to 11,000 in escalation. And this is only in the ceasefire situation. And there is uncertainty because we don't know which pathogen is going to be the one that will, whether it's polio, whether it's measles, and or cholera. And cholera could go up to like around 120,000 excess mortality if it's introduced in terms of the upper limit. And so this is a major concern, and there has not been laboratory testing in Gaza currently, so the detection systems that we're used to doing is not in place. In terms of maternal newborn, mainly the projections are due to the fact that people are not accessing care, not because of injury in this model specifically. This is a reduction in antenatal care, reduction in care for health facilities, so basically vaginal assistance for delivery and neonatal resuscitation. The decrease in breastfeeding, because in different conflicts in the region, but also the breastfeeding decreases. The decrease in wash the increase in food insecurity, and not only related to the access, but also to the quality of care that's being provided in the hospitals. And so we use the models to look at the excess mortality. Here, what we see mainly is that in terms of maternal death, you see that the light gray is what would be expected in this period, in 6 months, and the number would increase to around 28. However, I know that that people would see that these numbers are small in terms of maternal mortality. However, what we really refer to here is in terms of going back for more than 20 years in maternal mortality ratios. So the maternal mortality was actually quite good before the war in terms of like number. It was around 23. However, with the war, this is a healthcare system indication of going back 20 years in case of an escalation. The same when it talks about neonatal and stillbirth, and basically like with the fact that these numbers have not been seen, and just to look at it in another way, more of a cumulative factor from the beginning of the war to now. The light gray also is the mortality before the war, and then you see an escalation and a ceasefire scenario. Finally, in terms of NCDs, non-communicable diseases, what we did for the modeling was really rely on treatment and delay in treatment. So we know that type 1 diabetic, for example, if they have access to treatment, we wouldn't expect an excess mortality from that. But from studies that before the invention of insulin, we know that the life expectancy of a type 1 diabetic without treatment is actually very short, around 1 year. And so we use that to model, for example, what would happen with the case of insulin not reaching type 1 diabetic. The same thing with chronic kidney diseases. What we did is actually look at what would happen in terms of missing and skipping sessions for dialysis. In terms of ischemic heart disease, it's more related to basically like access to hospitals for surgery. And then in terms of stroke and also cancer treatments. And it's important to talk about the fact that a lot of the cancer patients before the war actually used to have permission to go get a lot of the treatment outside of Gaza. The only cancer hospital was bombed, and so this also was taken into account when we did these projections. And as I mentioned at the beginning, some of this is a bit probably an undercount of the excess mortality because of the fact that the models did not take into account COPD or asthma or type 2 diabetes. And so we multiplied basically the baseline mortality by the relative risk of change in access to healthcare with also the survival from the literature. And so basically, in terms of the projections, in terms of interruption of healthcare access, we'd see that the projection revealed very high elevated excess mortality from chronic diseases, mainly due to heart diseases, due to the lack of cardiac care, stroke due to the arising, like not able to have surgery, and neurologists that are not available, so specialized care, and type 1 diabetes, you see very high excess mortality, mainly due to disruption in insulin, and same with chronic kidney disease. So I want to mention at the end that we did not do projections for mental health. We might, but at the same time, it's important to note that high burden of mental health has been recorded in the region, and Gaza specifically. Gaza has one of the highest prevalences of psychological mental health burden. Mainly, the only psychiatric hospital in Gaza was bombed back in November, and a lot of the patients find themselves without treatments, and especially those who need specialized care, who need mental health drugs. As in any conflict, intimate partner violence is known to increase, and this is a concern also, especially with crowded shelters, and has been previously reported in previous wars. As some people have mentioned, UNICEF specifically, 17,000 children in Gaza are unaccompanied, so don't have parents, who were killed. And just to finish, just to say that in Gaza there is not really a post-traumatic, because the trauma is repetitive and continuous, and it's based on a Palestinian psychiatrist who tried to depict the concept of PTSD, or post-traumatic stress disorder, among Palestinians, to talk about the fact there is a chronic trauma, but an intergenerational trauma and an acute trauma. A child who's currently 16 years old in Gaza has lived through 6 wars. And so the whole traumatic experience, and not talking about also the water situation, the poverty, the blockade, and all the different aspects that come with that. And so just to finish off by saying that overall, we have projected the excess mortality from traumatic injury, endemic, epidemic, maternal, newborn, NCDs. But we have the total without the epidemics. So because we know the probability of an epidemic occurring might be 20% or 15 to 20%. So it's around 6,000 in a case of a ceasefire and 74,000 in case of an escalation. In case of an epidemic, the number will increase of mortality to around 11,000 in case of a ceasefire, to 85,000 in a case of an escalation. I just want to also point out the fact that a ceasefire today would save around 74,000 lives if we look at the epidemic and we look at the difference between an escalation and a ceasefire. And so not that we need more reason to push for a ceasefire, but yeah, to mention that. And as we said in the ceasefire, the majority of death would be due to infectious disease. The trauma death would be averted. However, there would still be trauma deaths because of wounds not treated. In the status quo, the excess death is due to trauma, but also due to infectious diseases. Escalation scenarios the same. Regardless of the scenarios, the malnutrition situation is becoming critical and also moving towards catastrophic in terms of classification, because you use the classifications based on prevalences of acute malnutrition. Regardless of the scenarios, infectious disease control and response is essential. We see, as I mentioned also, that there's a wide range of possibility of an epidemic occurring, and so more push towards basically preventing an epidemic from occurring while working on the wash sector, working on nutrition, working on the overcrowding. We didn't really depict all the interventions that need to be done, but some of it is something that we know really well in terms of public health practitioners. Political agreements need to be put in place to ensure that the security of healthcare workers are taken care of, and especially in the time of the conflict and the war, and ensure access to life-saving medication, and adherence to international laws to protect the civilians. Another key message to point out to. And as I mentioned, at the end, ceasefire would still lead to quite serious excess death. And this is something that means that if a ceasefire happens tomorrow, and hopefully, then we still have a lot to work on. And decision makers and humanitarian need to prioritize the healthcare system in Gaza, and that a ceasefire may save around 68 to 74,000 lives. Thank you so much for listening, and I'm happy to take in